Hi, everyone. My name is Kayla Fulginetti. I'm the Senior Director at Elephants&tea, and I am just so excited and happy to welcome you all to Season 3 of AYA Power, Moving Forward with Purpose. I am going to continue to let people in as they join, but we are so glad that you are here with us. As a quick reminder, AYA Power is our training and educational initiative, really looking at providing oncology workforce with education and resources. Each month, we get to bring in an expert speaker to share information and insights on topics that are really relevant to AYAs with cancer. And each of our sessions are recorded. So hopefully, when you joined in, you saw that recording button, which means I did it right. What this does, it allows us to really build a library of sessions and information that's accessible to anyone working with this population. I will make sure to drop in the chat our website, which is where we have a hub of upcoming sessions, all of our amazing speakers for Season 3, as well as all of the on-demand content. You can scroll down to the bottom of the website. That's where our on-demand content lives, and we're going to thank you to our sponsors, our founding sponsor, I'm Not Done Yet Foundation, and our supporting sponsor, Azi Pharmaceuticals. You will see that this is a really robust group of people, and one of the things that we love so much about it is the community aspect and really giving you all the opportunity to connect with our experts in the space. So please feel free to drop your questions. There will be a discussion at the end that Mike and Scott will facilitate, but we really look forward to that kind of lively engagement. We also just really want to recognize how hard the work is that we're doing. And for a short time, kind of while we're here together, just really hoping that we can feel us moving forward as we care for the young adult community. So with that, I will pass it on to my friend, fellow team member, Dr. Mike Roth, to introduce our amazing speaker today.
Thank you so much, Kayla, and welcome everyone. So good to see you guys. It is really a pleasure and a privilege to introduce my friend and colleague, Dr. Terri Woodard. Dr. Woodard is a professor in the Department of Gynecologic Oncology and Reproductive Medicine, and also the director of the Oncofertility program here at the University of Texas MD Anderson Cancer Center. She also holds a joint appointment in the Division of Reproductive Endocrinology and Infertility at the Baylor College of Medicine. She received her medical degree from the University of Pittsburgh School of Medicine and then completed a residency in OBGYN at Case Western Reserve Metro Health and Cleveland Clinic Foundation program. She then completed her fellowship in reproductive endocrinology and infertility at Wayne State University, where she stayed on as a faculty member until moving to Houston. Briefly, Dr. Woodard is an international expert in the field of AYA oncofertility. She has developed impactful fertility decision aids to assist patients and providers. She has advocated for fertility coverage for patients impacted by cancer and has educated numerous cancer providers on the importance of assessing and addressing the fertility needs of their patients. We are very fortunate to have Dr. Woodard's expertise back here on AYA Power. And on that note, I will pass it over to you, Dr. Woodard.
Thank you very much for that lovely introduction, and thank you all for joining me today. I'm going to just get my slides up here. And I would like to say that I was really excited about this talk. You know, a lot of times I'm asked to do didactics and talk specifically about fertility preservation options and, but to really kind of dig more into the meat of, what's important, where do we think this field is going, what can we do to improve care was a really exciting exercise to think about as I put together this presentation. All right, so first order of business, I don't have anything to disclose. And then the background that I was given as far as the session was that the AYA population continues to grow and the demand for accessible, comprehensive oncofertility care is becoming increasingly urgent. Addressing health disparities and resource limitations requires a forward-thinking approach to advancing reproductive care in this population. And so in my talk, I have pretty much three main goals. One is to discuss why oncofertility discussions are important. To briefly kind of go over the options that we have for fertility preservation that are available to patients. But I really want to take a lot of time presenting innovative strategies that can enhance the quality and delivery of oncofertility services to our patients. And really, when I think about my career and what I've hoped to accomplish in my work, is really generating access and promoting utilization when patients do want these services. So when I agreed to give this talk, I was like, yeah, this sounds really exciting. And then they sent me a slide of questions to consider. And I was like, oh no, wow. Some more things to think about. But it was funny because I was sitting there looking at these slides, trying to think. And then I was like, you know what? Let me go ahead and put the presentation together. And I think the answers will emerge as I put together the talk. And they do. So these are the questions. Where do you see the field of AYA oncology going in the next 3 to 5 years? What is one thing we can do together as a community to make real progress for AYAs now? And then given today's challenges, what creative ideas, partnerships, or interventions could help us improve care? And I hope that you keep these questions in mind as I go through this talk, because I think you will be able to see or kind of predict what some of my answers to these questions will be at the end. Okay, so first of all, why are discussions about fertility important? And I think the first thing that many of you pretty much already know, that young people do get cancer. Now, granted, it's not the majority of the population, but it's a significant portion of the population. It's estimated that in 2025, about 80,000 AYAs, or people between the ages of 50 and 39, will have been diagnosed with cancer. The good news is that the majority of these patients will be expected to survive, and the 5-year relative survival rate per SEER is about 86%. And this makes issues of survivorship increasingly more important. And one of those survivorship issues that often come up in this patient population is fertility. And study after study has named fertility as a priority concern for these patients. And the other thing about this is that most patients have predetermined expectations of becoming a parent. You never grow up thinking, oh, I'm going to need help, or I'm going to have to preserve my fertility to have a child. You just think, this is going to be something that I'm planning to do at some point in my life. We know from the literature that survivors express you will often find women, and occasionally the young man, who says, you know what, I could deal with the cancer diagnosis, but when you told me that I would not be able to have a family, that really hit me hard. And that's something that I'm still struggling with. So addressing this issue in patients is of utmost importance. And another thing is that it's been shown that even if a patient chooses not to preserve fertility, that just having this discussion goes a long way to improving their overall quality of life. Next, I want to talk a little bit about overlying principles, timing, decision-making, and collaboration. So really, when we talk about oncofertility and when we counsel patients, it's important to take a very global approach. Yes, the initial question is, okay, do you think you might want to have a family in the future? But we often have to make the patient think ahead, like, okay, will I be able to carry a pregnancy? What's that timing going to look like? What means am I willing to pursue to have a family? As medical care providers, I think our primary and most important responsibility is to educate our patients. It by far is the most important thing that we do. And there are multiple guidelines that exist regarding fertility preservation counseling in patients with cancer. The most famous one would be the ASCO guidelines that were developed back in 2012 and were just updated last year. but also the NCCN, as well as the ASRM, or American Society for Reproductive Medicine, also have guidelines that essentially say similar things. Basically, when you have a patient who has been newly diagnosed, you should initiate the discussion of potential infertility as early as possible in the course of treatment planning, so that patient has time to make decisions and pursue fertility preservation if it is possible. You should also be prepared to discuss options for fertility preservation. And if you're not an REI or fertility specialist, no one is expecting you to go into the nitty-gritty of it, but being able to say, oh yeah, you can freeze eggs, that takes about 2 weeks, or you can freeze sperm, we can usually get that arranged same day or within a couple days, goes a long way to letting patients know that this is something that is possible and that you're actually supportive of it. And then finally, for patients who, express that they are interested in having a family in the future, or even if they're kind of ambivalent and not sure, they really should be referred to reproductive specialists to have more in-depth conversations about their options. I alluded to this before, but anticipatory guidance is so important. We're not only talking about preserving fertility, but actually the mechanisms of how a patient might build their family post-cancer, given that we don't know what the future is going to look like. Another thing I would like you to appreciate is that this decision-making is incredibly complex. Some people do it a little easier than others. I've had patients where we're 3 days into an egg freezing cycle who say, you know what, I'm not sure about this, I want to quit, and that's okay. So there's so many factors involved, including, the time it takes, and am I having to delay my treatment to do this? Can I afford it? What are the risks to doing this? And having a patient make this decision in a short period of time under great duress is quite difficult. Teamwork in this area is key when we're taking care of these patients as reproductive endocrinologists. We really need our oncology partners to help guide us. We always call and make sure, like, okay, does this patient have time to do this? Do you have any concerns? Are there any other comorbidities that we have to be thinking about? I think one of the biggest problems with all of this is that access is a major barrier throughout the course of the cancer continuum and the cancer care journey. And whatever we can do to make access easier is important. And then the final point I want to make is that fertility is a continuing discussion. Yes, we ideally would see every patient before they were being treated, but sometimes that doesn't happen. Sometimes we do see them and they need to see us again in the course of treatment or after, when they're ready to actually have the conversation or as questions and concerns develop. So just kind of some brief overviews of fertility and cancer. How can cancer impact fertility? So one is by surgery, specifically if it's abdominal surgery that can alter the reproductive organs. Radiation, specifically to the abdomen and pelvis. The gametes, or the testes and ovaries, are very, very sensitive to even very low doses of radiation. So those are considered high-risk therapies. And then one other organ that people don't really think about that can affect fertility is radiation to the brain. While it doesn't cause gonadotoxic infertility, it can cause a patient not to make the hormones that communicate to the testicles or the ovaries to work. And luckily, that's an easy fix. We can give those hormones back. But a lot of times people forget that that can be a cause of infertility for patients. Of course, there's the anti-cancer therapies that include your chemotherapy, targeted agents, immunotherapies. And I think one big point to make here is that as we come up with all these better, newer drugs, a lot of times we don't even have good data about fertility risks in humans, and patients need to know that. And then finally, a category of people to think about are those that are at increased risk for cancer due to genetics. So these patients are at increased risk for cancer, and in addition, their offspring may also be at risk for cancer. So these are patients that often are sent to us to talk about fertility preservation as well. So what fertility preservation options are available? So on the male side, there's basically two main things. So for prepubertal boys who cannot make mature sperm yet, we have testicular tissue freezing, which is considered to be experimental. Although they are making some strides in this area, it's important to note that no babies have been born from sperm extracted from testicular tissue, but they're starting to think about doing the first testicular tissue implants. There's also hope that they don't even have to do the implant. There could be a way to utilize the cells in the tissue to make sperm in vitro that can be used in something like IVF. For postpubertal boys and men, the standard of care is sperm banking, which can be done relatively quickly. For men who can't ejaculate or for men who aren't making a lot of sperm, there is something called testicular sperm extraction that we've been able to arrange for our patients, where a biopsy of the testicle is taken and they get sperm that way, but that requires the services of a urologist. For women, there are a variety of fertility preservation methods. The standard of care or first line care would be your assisted reproductive technologies, which include egg freezing and embryo freezing. For these processes, women go through ovarian stimulation, meaning they take strong fertility drugs, usually on average for 10 to 12 days, and then undergo an oocyte retrieval. And they can either freeze their eggs or fertilize their eggs with sperm to make embryos that are then frozen for later use. Again, this takes about 2 weeks, is a bit more invasive and involved. For young women, or particularly girls who have not gone through puberty yet, similar to testicular tissue freezing, there is ovarian tissue freezing or ovarian tissue preservation, where we remove a portion of the ovary or an entire ovary, and then we can actually implant part of that ovary back into the body and it can resume its function and the patient can get pregnant. Now, this is no longer considered to be experimental. There are well over 200 babies that have been born using this method. Next, we have our ovarian suppression with GnRH agonists, which is considered experimental as well, but there's some data that suggests that shutting the ovary down while a woman is going through chemotherapy might make it more resistant to the gonatotoxic effects. And specifically in the setting of breast cancer, this has been shown, although the true rate of how it affects fertility is not quite known. If a patient is getting radiation to the ovaries or the uterus or the pelvis, ovarian transposition, we can move the ovaries up and hike them higher up into the uterus or into the abdominal cavity so they don't get as much radiation exposure. And then finally, another kind of category of fertility preservation that doesn't so much involve us as REs is the conservative management of early gynecologic cancer. So it used to be that when a patient was diagnosed with any stage of gynecologic cancer, the answer was a hysterectomy, bilateral salpingo-oophorectomy. So you'd remove the uterus and the ovaries. But now for each of the cancers, cervical, endometrial, ovarian, we have much more fertility-sparing ways of how to deal with it in hopes that that patient can eventually get pregnant and have a family. I always do like to point out in the consultations, because there are going to be patients that don't want to do fertility preservation, can't do fertility preservation because they're too sick, don't have enough time, don't have the money, that if you are open to other family building mechanisms, there are other ways to build families. And that can range from natural conception, because not all patients will become infertile after treatment, all the way to things like third-party reproduction, gestational surrogacy, adoption. And I don't want to say this in a flip kind of manner, because these options, especially when you get to the third-party gestational carrier type options, can be very time-consuming, very expensive, emotionally consuming, and depending on which state you live in, you might not have access to all of them. But I do feel like it's important for patients to know that just because we're having this one conversation at the beginning and you weren't able to do what you might have wanted to do, doesn't mean that you can't become a parent in the future. So, we have all these guidelines that state that we should be counseling patients and referring them, but obviously we know that that does not always happen. And the question is why? So I like to think of this in two major categories. So one is just access, right? Access to knowledge, access to counseling, access to services. So a lot of times people just don't know what they don't know. So patients don't even know to ask about this. They don't know to think about it. And as providers, if you're not, in GYN or women's health or reproductive medicine, you might not know much about it either. And the tendency for people is not to talk about things that we don't know a lot about, usually. Other issues that can arise are timing, when are these discussions appropriate if they're going to happen? And then in other terms of access issues, geographical, I think living in Houston, I take for granted, like we have so many resources, so many fertility practices, but I just saw a patient a couple days ago where when I put in her zip code, the nearest fertility clinic was over 200 miles away. So again, thinking about those patients that might be in places where they can't easily see a specialist is important. So at least getting them the information is even more important. And then, of course, there's the economic barriers. Most insurances do not cover fertility, let alone fertility preservation. So the other box I like to think about and kind of have experienced as I've taken care of these patients is how young adults interact with the healthcare system. So oftentimes they come in later with their diagnosis, so they're more advanced stage because, of course, a young person's complaining about abdominal pain and rectal bleeding, but no one's thinking colon cancer. They're not, so they have a delay in seeking care. As young people that are generally healthy and don't have to utilize the health system much, sometimes they're not sure how to navigate the system. And then a lot of them have competing priorities, like depending on the age, they might be in school, they might be just starting their careers, maybe they have young children. So seeking care and accessing it may be more difficult. The other things that we're starting to notice is that the attention spans, especially in the younger generations, seem to be a lot shorter, and health literacy isn't always where we want it to be. And I'll talk a little bit more about that in one of the interventions that we're trying to create, but just how they receive and interpret information can be very different than what we are used to. And then developmentally, these patients can be all over the place in terms of their degree of autonomy, agency, and self-advocacy. So these are all things that can really make it difficult for them to access and utilize oncofertility care. As I was putting this together, I found this little graph or table that I thought was quite profound in a lot of ways, but it really marks the transition points in oncology care for AYA patients. And when you look at this before, during, after, and all the things that are happening between, and you think about the ages of AYA patients, again, from 15 to 39, one patient can be 15 at the diagnosis and, 17 in survivorship, or someone can be 25 and 35 at the end. And that experience is going to be so different from those patients. And I think we have to remember that and really try to meet them where they are in that moment. So this is another wonderful table or graphic that I found. And actually, Dr. Roth was one of the authors on this patient. And, it was talking about, this paper was talking about how we improve care for AYAs. And it went over the different care delivery domains and things that we should be thinking about. And that intervention should be multi-leveled because, again, there's the patient level, there's the system level, there's the provider level, and trying to come up with interventions that address all of those is very important to come out with what is truly equitable care delivery. So going back to some of the original questions I was asked to think about as I was putting this together, there are really two things that we've tried to do in our oncofertility program or create in our oncofertility program to help address the issues of access and just awareness. And one was to create a decision aid. And what is a decision aid? It's a tool that's designed to help people make informed decisions about their healthcare options. And ideally, it presents clear, balanced information about the options, highlights the risks, benefits, and uncertainties, and helps people clarify their values and what matters most to them. And the overall goal of a decision aid is to improve patient knowledge, increase shared decision-making, and reduce decisional conflict and regret. So early on when I started, I realized I was having a hard time with some of my patients. They're like, tell me what to do. And I'm like, I can't tell you what to do. And I was like, oh, I met someone that makes decision aids. There was a gentleman by the name of Bob Volk, who's a professor in decision sciences at MD Anderson, and I met with him. And we decided to create a decision aid for women with cancer. And I think the beautiful thing about this project is that it was very, very patient-centered. They were the ones that told us what they wanted the decision aid to look like. For instance, we were thinking of having graphics with, white picket fences and baby feet. And they were like, no, this is about empowerment. We don't want that. We want something more sleek. So several years ago, we developed this decision aid called Pathways, and it's basically a fertility or a web-based fertility preservation decision aid site that helps women go through their options. And I'm going to walk you through some of those screens. So really, it's divided into three separate parts. So the first is setting the stage, kind of just talking about what the decision aid is about, what they can expect to learn from it, some basics about cancer and fertility, and just kind of setting the stage for having these discussions and providing some general terminology. The next part is comparing the options, and what was really important to patients was being able to kind of choose what options were available, depending on their cancer type. And I think it's the next slide that really shows that. But basically what we generated was the ability to pull up options and compare them side by side. So people could see, what option is appropriate for what patient, how long it takes, how effective it is, what are the side effects, what are the costs. So here is an example of the screen where you can actually pick a cancer. So you can say breast cancer. So it would pull up all the options for fertility preservation that are available to women with breast cancer. And then the final part of the decision aid is really making your personal decision. So we included some guided structured exercises for them to clarify their values and think about what was important. So for instance, do they prioritize starting treatment quickly versus having a biological child, or do they consider their partner when they're making these decisions? The other thing that was very important that patients told us, especially as AYAs, that we heard over and over again was that, I'm sitting in this room and I feel like I'm the only one my age here. Does this happen to other people my age? How have other people made decisions? So we included a part where we had patients talk about how they made their decision. Finances are a big thing. So we have links to financial resources that can help support patients by they pursue their options. And then we also have an area where they can put their zip code or address and find the nearest fertility. And these are some additional slides. So this is the myths versus facts slide. So we wanted to really drive home the main points that we wanted to get across when talking about fertility preservation. This is an example of our values clarification exercise. So patients can input whether something's important or not important. And at the end, they'll have a personal summary page that kind of spits out what seems the most fitting for them and what their values are. And then here is an example of a couple of different interviews that we did with patients who talked about what decisions they made. So for instance, Julia decided to do nothing. Elle decided to freeze eggs, and they talked about how they came to that decision. We did do some studies to see how well Pathways worked, and luckily it does work. We found that knowledge increased I think most importantly, I think patients found it to be effective, satisfying, helpful, and that it does really decrease decisional regret. So going through this exercise really did help patients process this information and come up with the decision that was right for them. So some further work that we're doing with the decision aid is we're working on a QI project with nurse navigators. So we have a nurse navigation system at MD Anderson. So our hope is to utilize them to get the aid out to our patients. There's also a version for AYAs that has been developed with St. Jude and WashU that is currently being studied. We actually have some basic translations into Arabic and Spanish to meet patients or to meet the needs of patients that speak those languages. And there's also an adaptation that was developed for lower resource settings by one of my former fellows. And excitingly, we actually are working on a male companion to pathway in phase when it's ready. So the next thing I wanted to talk just very briefly about, one of the biggest issues with AYA fertility care is access. So yes, we wanted to get access to information and decision support through the decision aid, but I think the biggest barrier is probably cost for many patients. There are a lot of patients that would preserve fertility but cannot because they just simply can't afford it. So one thing that we as providers can do, which I never really realized till I actually did it, was get involved with advocacy and political efforts. And while as a state employee, I can't say that I'm necessarily lobbying for something, I could serve as an educational resource to inform our legislative people like why this is important. And it took 5 years, but we were able to pass a bill in Texas, of all places, that helps many of our patients have access to fertility coverage through their insurance. And as you can see here on the right-hand side, this is a table from the Alliance for Fertility Preservation. It's a wonderful organization that helps states develop the language for bills, builds coalitions to get people together to really rally for this. I remember when we first started, this table did not look like this, but now you can see all of the states in green that have passed some form of coverage. It's not perfect. We still have a lot of people that aren't covered. There are limitations. I actually had a patient about a month ago where they would not cover, they would cover everything but the freezing of the eggs. So they would cover the ultrasounds, the blood work, the medications, the retrieval, but not the freezing of the eggs. So she had to pay for that. So there are a lot of little tidbits that are still very frustrating, but at least it's something she was able to do it. Okay, so that is the end of my talk. I know I've gone a little bit over time, but going back to the questions to consider, and I'm not sure if I should just go ahead and answer this, or should we go ahead and just open up the whole room to talk about them? It's up to you.
Yeah, Terri, if you don't mind just giving your spin and your thoughts on these questions, then we'll open it up. Okay,
perfect. So where do I see the field of AYA oncology going in the next 3 to 5 years? I think it's going to be booming. I think as more people are aware about AYA and cancer and the needs of this patient population, the demand for services is going to increase. Unfortunately, I don't see things getting easier for us in terms of having money, funds, time, personnel to meet those needs. But I think it's a great opportunity to think a little bit outside of the box and offer other things that can help fill that void. So for instance, that was the whole purpose of the decision aid, was to be able to reach patients in the comfort of their home on their phone, to prepare them for the conversation so that when they did go to the oncologist, or if they were coming to see me as a reproductive endocrinologist, they already had some background knowledge, which honestly saves me tons of time, saves the oncologist tons of time. So we could say, oh yeah, you just kind of need the referral, or yeah, you want to freeze eggs. Let's go ahead and get this started. So I think the use of technology, telemedicine, decision aids, things like that are going to be very, very important. What is one thing we can do together as a community to make real progress for AYAs now? Again, I had never considered myself to be a particularly political person other than going to vote and trying to be an informed voter, but getting involved at the legislative level was incredibly satisfying. And I felt like I was able to help so many more people through that mechanism than anything else I do day to day in the clinic. So I think for something like this, if you live in a state that is not green, reaching out to Alliance for Fertility Preservation, gathering people who say, this is an important issue for us. Is there someone who's working on this? Can you get us in touch with people who are, and not necessarily oncofertility, but other AYA issues as well, whether it's, genetic testing or, other types of resources. So I really think one place where we as physicians, because that's not how we're trained and we're not considered, to be experts at that, we kind of let that go. So I think, doing more at the political level is very important. And then finally, given today's challenges, what creative ideas, partnerships, or interventions could help us improve care? And again, I think the decision aid to me was like, it just made sense. It's funny, as we're developing the male aid and we're talking about attention spans, there's more talk of giving information in kind of nuggets or packets of information versus, a traditional didactic way of doing it. But figuring out how patients receive and process this information is very important, and really adapting to how they do that is important to make sure that the message is getting across. So that's it. Thank you.
Thank you so much, Terri. That was really wonderful. I will say we worked together and I've heard many of your talks and I learned many new things every single time that you present. So really just appreciate you coming to the group, sharing your expertise, knowledge, and then also appreciate your advocacy and spending off hours making sure that patients have access to care. Would love to open it up to the group. I have about 5 questions, but I will save my questions. I know we have a few in the chat. And I appreciate Stephen putting some of those questions. We'll definitely call on folks as well if you guys want to raise your hand. But that first question is, given the urgency of some of the cancer cases that come up and the consideration that the next best thing may be inclusion of hormone blockade, how much do hormone blockers help patients' odds of maintaining their fertility post-treatment?
Yeah, so that data is a bit muddy, and the best data comes from patients with breast cancer because they're the ones, or I should say estrogen receptor positive breast cancer. And there was a study done several years ago that looked specifically at women with triple negative breast cancer. And what they were able to show was that women who got the blockade had better ovarian function and had more babies than women who did not. But the problem is that study was not designed to answer the question of ovarian function and fertility. So for me, I feel like that's more of, I feel like it doesn't hurt. It could potentially help. So why not do it? But I would never encourage a patient to elect that instead of freezing their eggs or freezing embryos or something like that.
Yeah, that is super helpful. I will also note that there is an open trial across the country trying to help answer this question in AYAs who are not diagnosed with breast cancer. And please, if you are at an institution that's a part of the NCTN or NCOR, consider opening the ALTE 2131 study so we can actually have more evidence for that question. Moving on to the next question. Well, first I'll note I completely agree with Dr. Murphy's comment that I could listen to Dr. Woodard talk for hours and hours, and it's a wonderful presentation. The next question has to do with concerns about reimplanting cancer. So how do you make decisions regarding whether it's safe to preserve, freeze, and then whether that tissue is definitively without kind of cancer or that risk for reintroducing cancer?
Okay, so I want to make it clear for eggs, embryo, sperm, you don't worry about that because that's single cell. Well, embryos aren't single cell, but they're generated from single cell organisms, so that's not an issue. But certainly there is concern when you talk about ovarian tissue transplantation, testicular tissue transplantation. So when we're getting the tissue, there's always a portion that's sent to pathology to be looked at. In the United States, if a patient has certain types of cancers, we have been much more reluctant to transplant that tissue in general. Like, I've never put back ovarian tissue in someone who had leukemia per se. But if you look at the data from other countries, they have come up with ways to test the tissue. Also, the patient, before you harvest the tissue, should technically be in remission, which in some ways probably sounds counterintuitive to some people, because it's like, wait, don't you need to do it before chemo? But no, for ovarian tissue, for someone with leukemia, you actually want to get them into remission and then freeze the tissue. So there are cases of patients with even things like leukemia who've had tissue transplanted back. It was tested by various methods and appears to be safe so far, but I will say in the United States that hasn't been kind of the standard of care. Oh, can I add one other thing?
It's your topic. You can add whatever you want, Dr. Woodard.
But the other thing that is hopeful is that both for ovarian as well as testicular tissue, really, people are trying to find ways to mature the immature eggs and sperm that are in that tissue and just generate the gametes. So generate the sperm, generate the mature egg, instead of ever having to transplant the tissue at all. So that would be the ultimate hope.
Excellent. We have a few more questions in the chat. If folks want to raise their hand and come off mute, you're welcome to. I'm going to sneak one of my own questions in, which you had mentioned towards the end, increasing access and leveraging technology, and clearly you're doing that with the decision aid. Have you gotten any feedback, or what are your thoughts on the use of AI to help address some of these issues, specifically with patient privacy concerns? And what are your thoughts on kind of the future of getting patients access to Oncofertility care, and how or whether AI may play a role in that?
So I'm an older Gen X, so I'm a little leery about the AI. I mean, I can see all the wonderful things it does. I'm like blown away. My kids have to show me things half the time. So I think there's a lot of potential, but I think the problem is teaching it the right things and making sure that it in itself is equitable, right? So if it's being fed data that's not applicable to AYA patients, or being fed data that is not applicable to minority patients, or things like that, what you get out is potentially garbage. So I think, it has potential if done right and done ethically, but I do have a lot of concerns that, it might be created or used in ways that could actually be harmful.
Yeah, I think that's a really important point. I will say I share your amazement as well as concern. I'm specifically amazed that AI can help with my kids' geometry homework when I don't know the answer, but you worry that sort of regulation of the information being shared, that there's a lack of oversight as well. And how do we make sure that the information is being provided to the right patient at the right time, and it's sharing accurate information, because this is such an important decision. Other thoughts and questions from the community? There's a question about insurance and timing. So clearly, Terri, for many patients, time is a challenge, and making sure that patients get access to your services in a timely manner, and then navigating insurance can also be an issue. How does that work in terms of getting insurance approvals and timing, and does that slow you down in your practice?
Yeah, so for the actual consult, at least at MD Anderson, it's not an issue, because usually the consult seems to be covered. It's when you get to the treatment portion. And basically, once a patient has decided to pursue fertility preservation, they're going to do it at a specific fertility clinic. And that clinic will have a financial counselor who can kind of guide them through the process. So as soon as I see someone at MD Anderson who says, okay, I want to freeze eggs at Texas Children's, I'm reaching out to my insurance coordinator. She's running the benefits. She's doing all the back work to, see if we can utilize benefits, and if not, what other options we have for the patient in terms of philanthropic funds. For guys in sperm, that's been really difficult. I mean, luckily it's a lot cheaper, but still there are a lot of people they can't afford, $1,000. But sperm banks haven't been created in such a way to really accept insurance. So what we tell patients is, get your, bill, pay for it, and then try to resubmit it to the insurance. But it is a mess. It's a lot of work, and some clinics probably don't enjoy doing this, and they're like, you just have to pay for this and we'll figure it out later. But we do have someone that really works hard in getting approvals and prior auths and things like that.
I think that's really helpful, and I'll say a bias on the side of our clinicians who may not see a lot of AYAs in their practice. These are all barriers, and oftentimes any obstacle or concern often will influence our providers in saying, "Oh, that patient can't afford it, so I'm not going to refer them," because they don't want to make the patient feel bad that they can't, potentially go through with it. And what is your thought on what we should do as primary oncologists in terms of getting patients access to your knowledge and expertise and other specialists when a patient does have financial restraints, or we're worried about not making the patient feel bad that they don't have those options because of finances?
Yeah, that's a very good question. And in some settings, this could work, and in some settings, it might not. But I was mentioning that one of my fellows was looking at, using the decision aid in lower resource settings. So she was out in the Harris County system. And one thing that the patient said over and over again, like, don't assume what I can and cannot do. I want to know this information, and I'm angry if you don't provide it to me. So you will have the occasional patients that you think aren't going to afford it and then somehow do, or they have a relative that does it. I've had people GoFundMe and do things. So you'd be surprised at how people can pull things together. But again, the conversation itself usually should be covered for most places. Now, I know private infertility clinics, that might be a bit more difficult. But this is where something like the decision aid comes in very handy, right? Because it's accessible, and we hope to, it hasn't been widely available, although it was always meant to be because of branding and all the, MD Anderson stuff that has to happen that we're working on. But, our hope is that patients can see this, even if they're in some small town in Idaho. They can find a clinic if necessary. They can link to resources like Chick Mission, Live Strong, who do provide assistance, and work it that way.
Yeah, that's super helpful. No offense to anyone in a small town in Idaho. We do care about you and your patients. Thinking about the younger AYA population and the involvement of parents, how do you navigate that conversation with the patient who may be 15 or 16 years old and their parents? And clearly this is not something that they thought they would be having to address together at that stage in life.
Yeah, so it's really patient by patient, because the developmental levels between those ages vary so much. Like, I've had a 9-year-old who was able to articulate, like, I want to have a baby, so please freeze my ovaries. And then I have the 15-year-old who won't even look at me, or that the parents are saying, don't talk to her about this. So it's kind of about meeting the patient where they're at. If they are of an age and developmental state where they can assent, I always get that. I will take them in a room by themselves and say, do you understand what's going on? Is this something that you really want to do? Occasionally, I've had to get, ethics people or other members of the pediatrics teams involved to kind of try to come to some consensus on how we're going to handle things. But usually, if you can usually kind of get to a point where everyone's happy with the decision being made with the appropriate education and support. But I mean, really, I prefer the patients, if they're young, to be on board. Now, when they're super young and they're 2 or 3, of course, that's different. But generally, looking at adolescents, young adults, we can usually get there.
Helpful. And then along those lines, thinking about other considerations is thinking about kind of cultural background and how that impact some of these conversations. I will say anecdotally, we've had a lot of male patients who the parents will say, oh yeah, they've never done that before. They have no idea how to do that. And then 5 minutes later, they provide their specimen. But what's your experience been like in terms of when, clearly cultural factors, religion, and other things are a decision point for families?
Yeah, so I think the first thing is to be respectful, meet them where they are. So if someone tells me, I am devout Catholic, I don't believe in this, like, okay, we can move on. Or, there's been times like, for instance, I have quite a few patients that are virginal and having a transvaginal retrieval is a problem. So we talk through, okay, I can monitor you abdominally, but the retrieval is going to be transvaginal. It will be under anesthesia. I've even done abdominal retrievals for a few patients who just would not consent, which is harder, but we've done it. I've written letters, stating that this was a medical procedure that was necessary. So I think if you talk to the patient respectfully, kind of understand exactly what their concerns are, address them, again, you can usually get to a place where you have a plan that, you can move forward with. In terms of the young guys, I always wished we had a male. And the actual conference, sometimes it can be awkward. They're talking to, women, they're coming to the gynecology clinic if they're not coming to the AYA clinic. And sometimes a little humor helps with that. Like, no, I'm not going to put you in stirrups, but we're just going to talk about something that's very important. A lot of times humor will also go a long way as well.
Yeah, appreciate that. I feel like I'm kind of peppering you with questions like this is a firing squad, but there's so many good questions in the chat. We'll take one more, which is thinking about AYAs with intellectual disability and how to approach those conversations, who to approach those conversations with. Is that something that you've encountered before?
I've encountered it a couple times, and it's hard. And because the patients themselves might or may or may not be able to articulate their wishes. But of course, I can understand as a parent doing everything they possibly can to make sure that they were being a good parent and addressing all of their child's needs. The couple cases that I have had, actually I had one where we did do egg freezing. And it went okay. It went okay. I think the patient understood enough and was okay enough to do that. And then I can think of another case after extensive counseling and talking about everything that was involved. I think the family realized, well, you know what, maybe this isn't such a great idea. It's not doable.
Yeah, really, really helpful. So we are at the end. I will say this hour has gone incredibly quickly, and Terri, just a huge thanks for all you do. Thanks for sharing your expertise. I tell everyone on these talks when you do a really good job, we're appreciative, and that's great. And you also have the unfortunate challenge of being asked to come back next season. So yeah, just so much thanks to you for all that you do for these patients. And on that note, I will pass it back over to Kayla to wrap us up.
Thank you both. I am actually going to pass it to Scott real quick, who wanted to share a new initiative as well.
Thank you, Kayla. So we just to share for those of you who are new today. Well, first of all, thank you, Dr. Woodard. That was great. But for those of you who are not on our last session, we also are now offering something called Power Direct, where we are available to come bring AYA Power to your training programs. So if you're interested in that, please reach out to Kayla, Mike, or myself, and we will help coordinate that for you, that we can come. We have the speakers and the educational content to fit into your current curriculum. So if you feel like your program could use some additional speakers and experts within the AYA content, please reach out.
Amazing. Thanks so much, Scott. A huge absolute thank you to Dr. Woodard. As Mike said, it's a privilege to always have such wonderful speakers, and then you might get invited back again when you do so well. So we would be honored. But truly, we know this is such an important topic, and just thank you again for your time and your expertise. As always, I have two quick things to share. The first, I dropped a survey link into the chat for all of you that are here in attendance to give us some feedback about the sessions, about what you're looking for in the future. We truly value that information and use that to shape our program as we continue to develop it and build more content and more seasons. And then the last thing I'm going to share is actually a registration link for our next session. This one is going to be on, oh, I lost my date. Goodness gracious. It's in December. We know that. It is Dr. Onal Zhang. He's going to be doing challenges and opportunities in providing psychosocial and palliative care to AYAs with cancer on December 11th, and that is going to be at 3 p.m. I had to convert time on the spot in my head, 3 p.m. Eastern, 1 p.m. Mountain Time. So if you would like to join us again, please feel free to register there. You will get information, though, for those future sessions. And then we will continue on with Power into 2026. So thank you all so much for being here on this Wednesday. If you have any questions, please reach out to the team. Again, thank you, Dr. Woodard. Thank you, Scott. And thank you, Mike. Appreciate all of you so much.
Thank you guys so much. Thanks, Dr. Woodard.
Thank you. It's my pleasure. Lots of fun.